microphone. Hello, everybody, and those of you who roll your eyes every time you see me step up in front of a crowd, go ahead and do it and get over it, because I'm going to keep on doing this.
Okay.
Everybody knows me. I'm Sugar. I want to tell you. Hi, George. I want to tell you what happened to me in 1957. I had a baby boy who was so disagreeable, unpleasant, negative, just awful. And by the time he was a year old, I said, I will never do this again. But I was already pregnant. The second baby boy was just as agreeable as the first one was terrible. The second baby boy was a studious, wonderful child who studied all the time, who was loving, and did anything I said. If I leaned him against the wall, he was still there a half hour later. But today, that second baby boy is Dr. Peter Mouton, and I introduce him to you with pride. Pete.
Well, I could just say ditto to that. I was there. I just want to tell one little story. You all may not know who Martin Sheen is. He has 4 children, and they're all in show business, and they asked him, what do you think about all your children being in show business? And he said, to answer that, I have to tell you in advance, if these were not my children, I'd choose them as friends. One of my best friends, my son right here. Now, I'm proud of him yet. He said it reminds me of me. All the good things, which are not that many. But anyway, I gave you Dr. Peter Mouton.
Thank you very much. I want to also point out that I'm very lucky to have had good parents. And they taught me to work hard and study and respect other people. And to the extent that I've been successful, I have had a really great career. I'm still in the middle of it. But what I would like to do is thank them both. And I'm very proud of them, too, by the way. So what we're going to do today is talk about, as it shows here, memory, Alzheimer's disease, and successful aging. So I'm living in Tampa, working in Tampa, living in St. Petersburg, as you see here. And what I do in those places is research. I'm a professor at the University of South Florida. I also have a company that develops technology that helps scientists do research. And I'm a reviewer for the NIH, for drug discovery grants. So when companies are going to develop a new compound or a new medication, they send it to the government and we review it. We decide we want to put money into it, yes or no, and then that eventually gets to the FDA and possibly gets out to the pharmacy. So there's a lot of us, and we do a lot of hard work in that area to make sure the drugs that you get are safe and effective. So what I'm going to do is turn you over to one of my heroes, who is Eric Kandel. And Dr. Kandel is, you can't really talk about aging and memory if you don't talk about the contributions of Eric Kandel. So I want to let you hear him in his own words tell about himself. He was a refugee from Austria, and he went to Harvard University, went to Columbia University, and made some remarkable contributions to the study of memory.
Doing science is a very satisfying way to spend one's career. Pick a problem that is really important and try to tackle it in a very, very serious way. Don't do a trivial problem. It's better to make small progress on something really, really important than to push a trivial issue further ahead. My scientific questions often come from things that I have personal interest in. I went to Harvard and majored in history and literature because I wanted to understand what happened to me in Vienna, 1938, when Hitler marched in. I wanted to see how, civilized people could become so brutal and anti-Semitic. While I was writing my dissertation, I met a famous psychoanalyst. He said to me, if you want to understand motivation, if you want to understand what happened to you, you're not going to do it from history and literature. You've got to really study the mind. You've got to study why people do things. You've got to study psychoanalysis. I had no science background whatsoever. I took physics, I took organic chemistry, took the courses necessary for medical school, and I went to medical school with the idea of becoming a psychoanalyst. I came along at a very good time when neuroscience and psychology, which were worlds apart, was beginning to come together. I was one of many people that contributed to that. There were people before me that already started the way. But I took advantage of the fact that this was a new direction that was opening up. There were certain experimental systems that were conducive to that. And many neuroscientists of my generation were scared to work on behavior because they thought it was too complicated. And I, being a psychiatrist, that didn't bother me in the slightest. So I learned how to study behavior, worked out a simple movement study, and see what happens when an animal learns something. And I found that what happens is that the strength of synaptic connections changes. And nerve cells communicate with each other at specific sites called synapses. And these synapses are changed by learning. In certain kinds of learning, the synapses get stronger. The other kinds of learning, they get weaker. Well, I think working out the first cellular mechanisms of learning and memory is not so bad. I'm quite proud of the fact that I did this. Way beyond that now, the field, which was very small when I came into it, is now gigantic. Many people work on the brain, different aspects of behavior, and making very good progress. So the brain is unbelievably complicated. We've got decades and decades of work ahead of us, but very good progress is being made.
So, Professor Kendall won the Nobel Prize in 2000 for his contributions to studying memory, and of course that extends directly to Alzheimer's disease. And so that's what we're going to talk about today.
Food science is very satisfying.
Sorry. And he wrote a very interesting, a very popular, and well-written book called In Search of Memory. And he laid out exactly how to make a major discovery, how he did it. It was quite incredible and changed the way we think about memory, and it helped us to understand memory. He's still working. He's about to turn 94. And here he is with his subject, aplesia, which is a sea slug. And he said he wasn't afraid of behavior because he picked an animal that was so simple that you could understand behavior if you could just understand the behavior of this sea slug. And that's how he made his contributions. So what we learned from Professor Kendall is that memory is due to two things. One of those things is attention, and the other one is perception. So memory is equal to attention plus perception. And as you know, perception is touch, seeing or sight, hearing, smell, taste, and emotion. So if you're not paying attention to something, you cannot learn it. You can't remember it. And if you can't perceive that, you can't remember.
Could you change to a handheld mic?
Or clip it.
Is that better?
Well,
Yes.
Okay. So, is that better? Okay. So we need to remember this when we think about memory and we think about aging, that when we age, we lose some perceptions. So maybe we don't see as well as we did before. Well, we need to get better glasses. Maybe we don't hear as well. Well, we need to get a hearing aid. And maybe we're depressed. We need to deal with that depression. Because all of these factors contribute to your memory. You can't learn it, you can't remember it if you don't perceive it. And you also have to pay attention to it. These are the two most common reasons why people think they have memory problems. Well, if you improve the perception and you improve the attention, sometimes you can improve memory. Well, what Professor Kendall showed and his group of researchers is that when you have attention and perception, the brain actually starts to make the components of memory. It learns how to encode and store and retrieve. And when that happens, you have recall. So memory begins with attention and perception, and then it goes to recall. And what's happening, and they actually explained this as well, what's happening is that we are seeing a reverberating cycle. So this small little cycle starts reverberating about that memory. And the more repetition, the stronger that trace becomes. So we have, our memory is really a series of traces. And if something significant happens that makes you want to remember that in the future, then what we have is an actual long-term memory. The things that are not important, we don't really want to clutter up our minds with, so we don't really want to save things that are not significant. But if we sense that it's extremely important, you can go directly to long-term memory without going through short-term memory. Examples are when the trade towers came down in 2001 on 9/11. Immediately, we all have long-term memory trace about that. When John Kennedy was assassinated in 1963, you immediately can tell everything that's going on in your world at that moment. You immediately remember everything. But for the most part, we have short-term memories that are consolidated into long-term memory. So this is really how memories occur. And this is what Professor Kendall and his colleagues got the Nobel Prize for in 2000, for pointing these things out by doing their research on aplesia, on this sea slug, and proved that memory works in this manner. Well, it turns out that memory works in our brains the same way. So the anatomy of memory in the human brain focuses on a couple of different regions. One of them, which you may have heard of, is called the hippocampus. This is where short-term memory occurs, here in the base of the brain. The other area is called the prefrontal cortex, that's shown here in blue. This is where long-term memory is. You have some other memory areas. The cerebellum is your motor functions. How do you remember how to play the piano? Your hands move. Anything, you're sewing. If you sew, how do you remember how to sew? The memory of those things is located in the cerebellum, down here, the base of the brain. And then you have your fear responses. That's called the amygdala. So let's say you got bit by a dog when you were a kid. Well, now when you see a dog, the fear response comes back. That's a protective reflex to stay away from dogs because dogs can bite you. But for the most part, what we're going to be talking about today are short-term and long-term memory, and those exist here in the brain. Now notice, three of these regions are down here in the base of the brain, so they've been around in evolutionary terms for a very long time. Alligators, for example, have these parts, and they have this. What they don't have, and what is very recent, only amongst primates, so it would be humans, it would be chimps, monkeys, they have a cortex, and this is where we can store our long-term memories. It's like the hard drive of your computer. So you have the short-term memory here, and then when it's important, it's saved to the cortex. So let's talk about forgetfulness. So we've all had this experience where something's on the tip of the tongue. And we're trying to remember that word or remember that name, and we just can't seem to do it. And the first thing we think of is this normal? Or is this some evidence that something's wrong with me? So what is forgetfulness? Is it normal? Is it expected for people my age? Or is it mild cognitive impairment, which is one step more severe than normal aging? Is it early Alzheimer's disease, we sometimes think? Or is it some other form of dementia? So what are other forms of dementia? Let's talk about dementia for a minute. Dementia is really an umbrella term, because within dementia, there is Alzheimer's disease, which is 60 to 80% of all dementia. There is Lewy body dementia, which is about 5 to 10%. There's vascular dementia due to blood vessels. That's about 5 to 10%. And then there's what's called frontotemporal dementia, or FTD, and that's about 5 to 10. And then there's others, like Parkinson's disease or Huntington's disease. These all also have dementia components to them. So when we think about dementia, it's an umbrella term for loss of memory and other thinking abilities severe enough to interfere with your daily life. Maybe it's easier to see it with a pie chart. So you see this blue part right here is Alzheimer's disease. So yes, the majority of dementia is Alzheimer's. But Alzheimer's and dementia are not the same thing. You have dementia, and then you have Alzheimer's. And then you have Parkinson's. And then you have vascular dementia. And then you have frontotemporal dementia. So let's go back to forgetfulness. What is forgetfulness? Trouble finding a name or the right word. We're talking to our friend, and we're just having a conversation, and you just can't seem to get that word. It's on the tip of your tongue. Sometimes you forget new people's names or their faces. Someone you just met, and you can't remember their name. Sometimes you have a difficult time with errands or tasks at work. You can't remember something you just read or learned. Or you lose or misplace valuable objects, such as your wallet or your keys. Or you're having problems with planning or organizing events. This is what we call normal forgetfulness. And the question I would ask you to ask yourself when this happens to you is this different? Or have you been like this your whole life? Have you had a hard time remembering people's names? Are you doing too many things? And so you forget, you're not paying attention where you put your keys, but you eventually find them. Your wallet is not your normal place. Well, do you always put your wallet in a different place, or do you always put it in the same place? So you have to ask yourself, is this different, or is this how I've always been? Someone asked me one time, I just can't seem to remember people's name. I must have met 15 people, and I can't remember their name. And I said, has this always been like that? Oh yeah, ever since I was a little girl, I couldn't remember. Well, then there you go. So that's not new, so it's nothing to worry about. That's who you are. So going back to the idea of memory and attention and perception. If you talk to somebody and you look at their face and you use their name 3 times, you're going to hear it, you're going to say it, I bet you're going to remember it better. You look right in their face and you use their name. So now you're going to get memory equals attention plus perception.
Yes.
So keep that in mind when you think you might be having a forgetful moment or your so-called Alzheimer moment. Were you paying attention to that? Or could you hear it? Or did you not see it? M equals AP, or MAP. You can improve A, N, or P. You can improve attention and improve perception may also improve your memory. Simple thing you can do. And sometimes when you're not doing anything really important, you might just sit there and go, what are all of the sounds I can hear right now? Well, I hear a golf cart going by, or I hear the TV in the other room, or someone's talking on the phone. Just sort of practice getting good at paying attention to things. That might help. And as I've already mentioned, you can go see the optometrist, get your prescription checked, get your hearing aid checked, and if you're depressed, talk to someone about that. Maybe get on an antidepressant medication. That will allow you to have better memory. You'll be paying attention better. So then there's some reversible causes of poor memory. One of those is an infection. If you have an infection in your body or an immune reaction, it can interfere with your ability to remember things. Metabolic problems, hormone abnormalities can also interfere with memory. Vitamin deficiency, B12, niacin, which is B3. If you take a B complex of vitamins, you can deal with some vitamin deficiencies that happen because of our digestion. As we get older, it doesn't work as well. And the B12, the B complex vitamins are absorbed in your stomach. Okay? So if you're not absorbing well, you're not going to get enough B vitamin. Medication side effects, very common, especially when you start a new medication. Start a new med, you're going to have a period where there's going to be interactions with the other meds that you're on. So you might sometimes seem a bit confused, but you'll get over that. It'll eventually work itself out. But especially at the beginning, you can have drug-to-drug interactions. If you have a head trauma, you can have a subdural hematoma. You might not even be aware of it, and it can be putting pressure on your brain. Any type of poisoning, if you get poisoned by something you ate or something that gets under your skin, can cause memory loss. Excessive alcohol, of course, we know. I don't remember what I did. I was drunk, right? You weren't paying attention. If you're under severe or moderate stress, again, you're not paying attention because you're stressed by something. And then, of course, a brain tumor or a stroke is going to interfere with memory. I say these are reversible. For the most part, they are. And then what's called normal pressure hydrocephalus, which is basically water accumulating in the spaces in your brain. It can put pressure against the other parts of the brain that control memory, and that can cause you to have memory problems. All of these can be diagnosed. So if you think you might be having poor memory, you need to go see a neurologist and you need to get a workup. And they'll do a cognitive test. Typically, they'll give you the mini mental state exam, also called the Folstein test. You can have a brain scan, an fMRI, a PET scan, or an MRI. All of these be able to see if there's anything wrong physically with your brain. You can have a neurological exam, which we've all had. Well, they'll check to make sure that you're cognitively intact. They will take your medical history. They might do some genetic testing, because we're going to talk about that here in a minute, that there are some mutations that are related to Alzheimer's disease. And there's some new blood tests. New blood tests are coming out all the time, but there's some new ones that are being used to diagnose Alzheimer's disease. So what does an MRI look like if you have Alzheimer's disease? So this is the normal, and the areas we look for here are the hippocampus, right here, this area down here at the base of the brain on both sides. This is the cortex out here. It's like the cortex, the outside of a tree. And these are the ventricles. These are those spaces that are inside. Well, this is an Alzheimer's case. And when you look at this, you can see these sulci and these gyri are enlarged here. The gyri are enlarged, the sulci are smaller. You also see there's some shrinkage. There's more space here in the ventricle. And if you look at the hippocampus here versus here, it's shrunken or atrophied. It's smaller. And so this would be an indication that there may be something going on related to Alzheimer's disease. Other tests can be done. It's called a PET image. And it's a little more invasive. It's got radioactive tracer, but basically it's looking at where is the blood in your brain going. And it's looking at the utilization of glucose, which is in the blood. And so you can see here in Alzheimer's disease, the utilization of glucose is very low compared to normal. So the activity in advanced AD, here you can see it in early AD, you can see more of the purple than here, but then it just gets worse in advanced. You can also have a lumbar puncture, which if anybody's had, you know that's no fun, but there is a lot of information that can be obtained because the cerebrospinal fluid in your spinal cord actually bathes the brain. So whatever is in your brain is also down in your cerebrospinal fluid. So if you take some of that fluid out, you actually see like the bath water around your brain and see what's being deposited there. Now the next step in Alzheimer's disease is what's called middle stage or probable. And that is when you forget your own personal events or your own personal history, not things that happen, not episodes that happen to you, but your own things where you went to school, for example. Or you may become more withdrawn, socially or mentally challenged. You pull away because you know you're having problems. Unable to recall your personal address or your phone number or the schools you attended. Confusion about date, place, or time. You're not sure what is the day. I mean, sometimes days run into each other, but when you stop and think about it, you can say, okay, yeah, it's Saturday, yeah, for whatever reason, you'll remember. New problems with words or speaking. You never had any problems speaking before, now suddenly you're having trouble getting the words out. If you have a change in your sleep pattern, that's usually a good indication that something's going on. It may be due to stress, it may be due to your diet, it may be due to the coffee you drank before you went to bed, but for whatever reason, a change in sleep pattern is an indication something's going on. Particularly in Alzheimer's disease, wandering. And wandering means that sort of the boundaries are sort of disappearing. And so you don't see that you're getting outside of your neighborhood, of your normal where you go. So you can't remember your boundaries, and you're starting to wander. Difficulty with familiar tasks like gardening or shopping. You can't remember what the cart does at the grocery store. Or you can't remember what do you do with this handheld hoe or this shovel. And then suspiciousness, there's a kind of a paranoia that can happen, particularly of people around you. You can also engage in unusual compulsive behaviors, repetitive hand washing, or shredding tissue, things like that. These are abnormal for you, then that's something to be concerned about. So let's talk about Alzheimer's disease for a minute. Why are we calling it, what is this name, this Alzheimer name we're talking about? So Alzheimer was a real person, Aloysius Alzheimer. And he lived in the late 19th century and early 20th century. And the name of this disease came to him quite by accident, actually. He had a patient whose name was Auguste Detour. And she was German, housewife, who was a little bit older, about 14 years older than Alzheimer. And he encountered her in a clinic one day. Her husband, she was very suspicious of her husband all of a sudden. And he just got to the point where he couldn't take it. He took her to the hospital and said, you've got to figure out what's wrong with my wife. And so Alzheimer became extremely interested in this case and followed her for the rest of her life, actually. But he made some copious notes, and some of those notes have been published recently. And she was presented at age 51, so very young. And he said her memory is seriously impaired, he wrote that. If objects are shown to her, she names them correctly, but almost immediately afterwards has forgotten everything. When reading text, she skips from line to line or reads by spelling the words individually or by making them meaningless through her pronunciation. In writing, she repeats separate syllables many times, omits others, and quickly breaks down completely. Remember, she's 51. In speaking, she uses paraphrased expressions like milk pourer instead of cup. Sometimes it's obvious she cannot go on. Plainly, she does not understand certain questions. So he got to know her pretty well. They developed a good relationship, and he followed her and does not remember the use of some objects. So when she passed, he took her brain, he sliced it up, and he looked at it under the microscope. He went to some colleagues of his who had just developed these new techniques for staining the brain, and he identified these microscopic particles. And he would take these slides, the meetings, and pictures of these slides, the meetings, and show these to people at conferences and say, what do you think this is? This is very unusual. He would tell her story, describe her clinical history, and then say, what is this? I've never seen this before. He was a pathologist, neuropathologist. And they started calling it Alzheimer's disease. He would travel around and they would say, have you heard about Alzheimer's disease? Well, Alzheimer has this case, and he has these slides from this case, and so on. And so it became known as his disease, quite by accident. Now, one thing we would do today, which we didn't do at those times, at that time, she was given the diagnosis of pre-senile dementia. But what we would call that today is early onset Alzheimer's disease. But I want you to notice something. This is the age at symptom onset, and these are different genes that we know can mutate. And when they mutate, the person gets Alzheimer's. But age 50 is where most of these cases happen. And this is the most severe type of Alzheimer's there is. So you can all be, I'm thinking all of you can be pretty confident you're past this problem, right? This is not going to happen to you. This is the worst type of Alzheimer's. So you're also, by the way, past most of the really bad cancers, which happen typically when you're younger. So you probably don't have to worry about early onset Alzheimer's. Late onset Alzheimer, of course, we all still have to worry about it, but it's not as severe. And the symptoms are very treatable. So that's sort of the good news. Like I said, the pathology of Alzheimer, and this is where I work. I'm a neuropathologist, so I study Alzheimer's from the point of view of studying the brain. It's a progressive disease, so it's not the same as aging. And it used to be thought that it was. But we now know that if you're going to go down the path of normal aging, you may get some of the changes that occur in Alzheimer, but it's not the same thing. Alzheimer is a very different animal. You have loss of brain cells and neurons and their connections. Those are called synapses. And that causes this shrinkage that occurs in Alzheimer compared to an age-matched healthy brain. You can all see that difference. You have loss of memory and other important functions. There's currently no cure for Alzheimer, and medications and management strategies will temporarily improve the symptoms. But it doesn't change the course of the disease, it just makes the disease easier for you to live with. So at post-mortem, at autopsy, you have a normal aging case, you have an Alzheimer's case. This is half of the brain, this is the midline, this is the lateral, this is what we call the ventral, and this is dorsal. And you can look at it and you can all see that there's a lot of atrophy here. But let's look at particular areas. These are sulci, the little indentations in the brain. You can compare those sulci, they're much deeper on the Alzheimer's side than on the normal side. The gyri are larger. You can see how the gyri is larger there. They get smaller here, they're shrunken. The ventricles here are larger in the Alzheimer case. Here again, you see the sulci are different. And this area that controls memory, the hippocampus, is much smaller in the Alzheimer case. So this is where we start. Now what we try to do is can we make an animal that we can study, and then we can try to cure the animal, and in doing so, maybe develop a drug for treating Alzheimer patients. So we still use Alzheimer's pathology to diagnose the disease. It's diagnosed at autopsy. From a pathology point of view, you can't have Alzheimer's disease if you don't have Alzheimer's pathology. Just to let you know, from a clinical point of view, clinical people have a totally different view. They say if you don't have dementia, then you don't have Alzheimer's. But a pathologist would say if you don't have these Alzheimer pathology, you don't have Alzheimer's. So just so you know, there's two schools of thought about that. So these amyloid plaques are present in normal aging, but as we're going to see, it isn't necessary that you're going to develop dementia just because you have a lot of amyloid plaques. The other thing that Alzheimer found, and we still use today, are what are called neurofibrillary tangles. So these are inside of the actual neurons. These are outside of the neurons, and it's amyloid. It's sort of like a gum. It's very sticky. And what happens is the brain tries to get rid of this sticky substance, amyloid, and it causes these sores all over the brain. This is a sore, and it has all of this inflammation around it. And you can imagine all of that inflammation, millions of places in your brain. What if you have some neurons that are passing information and it hits this? Well, it's not going to get through that, is it? It's going to stop right there. So imagine this millions of times across your brain, and this is what's interfering with your memory. Same thing with these neurofibrillary tangles. If this is a neuron and it has all these tangles in it, it's not going to be able to function normally. So this pathology is very important for interfering with the memory. So what is the cause of Alzheimer's disease? What is really going on here? Well, for one thing, we don't know. The short answer is we don't know what causes Alzheimer's. What we do know is there's something called an amyloid cascade. And this amyloid cascade theory of Alzheimer's is that you have a normal neuron. This is the cell, and it goes and it jumps across the synapse to this next cell. But as time goes by, you get this amyloid deposition, and it causes inflammation. AD is the amyloid, and you get this sore. And this happens all over your brain. And then eventually you get tangles inside those neurons, and eventually the neuron dies. So you have a lot of cell death in Alzheimer's. You don't have that in normal memory. And that's why we say Alzheimer's is not just accelerated aging. It's some different animal. So at the very core of Alzheimer's, now we're talking about dementia. There are over 100 trillion synapses in your brain. This is where cells communicate with each other, at a synapse. There are 100 trillion, more or less, synapses. So this is neuron 1. You have a chemical released into that space, and this is neuron 2, and so the impulse jumps across that space like a spark plug gap. Just jumps right across there. And what happens is what are called neurotransmitters are released on this side and carry the information across to the other side through this space, this synaptic space. And when those neurotransmitters connect on the other side, then the impulse continues going. But if something interferes with this process, that's going to interfere with the synaptic transmission. So what is it that interferes? Well, we know one thing is the amyloid. Amyloid gets down in that synapse, and it interferes with the neurotransmitter connecting to the other neuron. So amyloid is present in the synapse. So the number of synapses in your brain go down. This is a control person, the total number of synapses they have. This is someone with MCI, or mild cognitive impairment. Still not by any means Alzheimer's disease, but maybe a little bit not as good memory as one's had. But when you go to Alzheimer's disease, there's a significant 25 or even 30% drop in the number of synapses. It's where the two cells communicate with each other. Those die out. The fewer the synapses you have, the more severe your dementia. So if you have this low number, this is increasing number of synapses. If you have a low number of synapses, you have this is how good is your memory. Low number of synapses, you have very poor memory. As your number of synapses increase, your memory improves. And in the case of Alzheimer's, as the total number of synapses decreases, as shown here, declines, so does your memory performance. So at the very base of Alzheimer's disease is loss of synapses, no longer making the connections between neurons. And how does it progress? Well, it starts off in a preclinical diagnosis. That's where you're just starting to have some early signs eventually. And so this is when you go from normal to abnormal. You're still sort of preclinical, you're still normal, but you're starting to get abnormal there. When you get to MCI, it's getting abnormal. So as you move across here, you get to dementia, then it's very abnormal. So the disease actually progresses along a very, very clear pathway. And all these different colors are the different pathologies that occur. So this is where your cognitive loss starts. Here is where your synapses are starting to be lost. This is where your amyloid is starting to accumulate. So you can see the amyloid accumulates, the synapses are lost, you start having neurofibrillary tangles, the brain starts to atrophy or shrink, you have cognitive impairment, and now you go to the doctor and you say, I think there's something wrong with my brain. Well, this has been going on for 10 years. And this is the difficulty of studying Alzheimer's disease. We might have a drug and we want to test it on somebody, but by the time they start showing symptoms, they've had it for about 10 years. We would like to know who is going to get Alzheimer's disease, give them the drug before they have all this pathology, and see if the drug works. The problem is we don't know who's going to get Alzheimer's disease. And by the time you're starting to show the symptoms, you've already had it for 10 years. Make it just a little more difficult, right? So the 10 to 15 to 20 years in a lot of cases, that by the time you present, you have already got very, very severe pathology. What is the chance that if I give you this drug today, that it's going to make all of that pathology go away and cause you to come all the way back here to where you had normal cognitive function? That's pretty difficult. So we study animals, and we try to treat animals before they have it really bad and see if it prevents it or slows it down. Because we can't know who to give it to as far as people. So this is where you would like to start an anti-Alzheimer drug, but you don't know who to give it to. So what are the risk factors for Alzheimer's disease? First of all, there's some that we just can't change, right? You can't change how old you are. You just have to accept it. Your family history, if you have a lot of Alzheimer's in your family, you tend to have more of a risk for Alzheimer's disease. It isn't exactly one-to-one, and I'll tell you this right now, a lot of people who think they have a relative with Alzheimer's disease may have a relative with something that looks like Alzheimer's disease. So unless that person has had an autopsy and has had it confirmed as Alzheimer's, that person may not have had it. May have had a vascular dementia, or maybe had some other type of dementia. So be careful about assuming that so-called relative, your great aunt, had Alzheimer's. Maybe she did, maybe she didn't. ApoE4, this is what's called a susceptibility gene. If you have this gene, if you actually have two copies, one from your mother and one from your father, then you have a higher risk. It doesn't mean you're going to get it, but it means you're more susceptible to getting it. If you have Down syndrome, now this is something that's probably most people don't know, that Down syndrome, all of people who have Down syndrome eventually get Alzheimer's disease. Because they have 3 chromosome 21s. It's called trisomy 21. And one of the things about you normally get one from your mother, one from your father, right? You have 2. Well, in Downs, you get 2 from one of your parents. You have 3 number 21. And on 21 is where the amyloid is made. So you have a triple dose of amyloid. And it gets to a point where it just gets saturated and it forms these amyloid plaques. So every person, their onset of dementia may be different, but they will all have the pathology of Alzheimer in their brain because they have all of this amyloid. This actually turns out to be something that we're using now as a test of different drugs because you know they're all going to get it. So if you give someone with Down syndrome an anti-Alzheimer drug and you can delay the onset of dementia, well, that's an indication that this might work in other people. And then a previous brain injury. You can't change these things, but if you had a previous brain injury, then you have a higher probability of getting Alzheimer's. So there are some risk factors that can be changed, and these are the things that we want to change. A healthy diet. Everything you eat, everything you put into your body, you should think of food like it's medicine. And it gets into this synapse. And it can have a side effect, just like medicine can have. So if you eat something that has a lot of carbohydrates, for example, that can have a bad side effect, just like a bad medicine. So alcohol use. Alcohol use can interfere with your synapses, just like things that are not good for you in your diet. Exercise can help clear out these synapses, can bring blood to the area, and the blood will carry the amyloid away. Good sleep. What happens when you sleep is all of this is cleared out. When you get good sleep, your mind is cleared of all of the things you've been thinking about. Well, all of those things you're thinking about are in your synapses. So by getting a good night's sleep, you're actually clearing out your synapses. Avoiding a brain injury, simple, right? Wear a helmet, you're riding a bike, you're riding a Segway. Whatever you're doing, don't fall down and hit your head if you can avoid it. Improve your cardiovascular health. If you're a person who tends to have plaques, coronary artery disease, you need to get a stent, or you need to have a jump, you need to have a bypass. You need to, whatever you need to do to improve your cardiovascular function. Depression, as I said, depression can interfere with your ability to pay attention to things. It can also lead to accumulation of amyloid. You're not sleeping well. You're eating bad things. You're depressed. You're drinking alcohol. These are all related to depression. Diabetes, also, you do not have good blood supply when you have diabetes. So you want to deal with these things that you can. I don't even have to tell you how bad smoking is. Everybody knows that one, right? So, and then vitamin and nutritional deficiencies. We already talked about that. When we get older, we don't absorb as well as we did through our stomach. And so your vitamins may not be being absorbed. So you may need to get a B shot, a B complex shot, a B12 shot. So these are things we can avoid. And when we do, we can clear up the A beta out of our synapses. So let's look at our risk factors again. We have successful aging on this side. We have the amyloid cascade on this side. So if we don't do anything, we live just whatever life we feel like, we don't even think about this stuff, eventually it'll be on the side of aging, diabetes, you may have ApoE, or you may allow yourself to get obese. Well, these are some things you can do. You can improve your heart health, improve your diet, get better exercise, to tip the scale over to successful aging. So your risk factors are here. You need to offset those with these. If you do that, you can reduce your chance of getting Alzheimer's disease. You get better sleep, you improve your diet. You may still be obese, you may still have an ApoE, you may still be getting older, you may still have some mild diabetes, but you can also offset that by improving your behavior, the things that you do that could contribute to unsuccessful aging. So let's talk about an amazing study that was done. It started when I was in graduate school in 1986, and it went till 2009. And some people realized that nuns are the perfect group to study because they live in a clustered environment. They basically eat the same food, and no matter where they are, they have a very sort of regimented day. Their daily life is regimented. So they organized what's called the nun study. And they studied nuns and found to try to figure out why does some nuns do better than other nuns. That is, some nuns get successful aging and some get Alzheimer's disease. Since they all sort of live the same life, what's the difference? So what the nun study showed was that nuns who engaged in more social, physical, and cognitive activities and expressed more positive emotions were less likely to get dementia. And here's the big thing. Including those whose brains had large amounts of Alzheimer's disease pathology, including amyloid plaques and tangles. So what that means is that you can actually overcome the fact that you have neuropathology of Alzheimer's by improving your risk factors, by engaging in social activity, physical exercise, cognitive activity, and have more positive emotions. Don't be depressed. You can actually offset the effects of the Alzheimer's pathology that's in your brain. So when you take these people to autopsy and you look at their brains and you show it to a neuropathologist, they'll say, that's Alzheimer's. Then you say, well, that was somebody who, I think I lost my mic.
I think it went dead.
So, oh, here we go. So, hello?
I don't know. Maybe the internet went down.
Hello?
Just, you can yell.
No, just give me a second. Let me.